Alright, neuro nerds, so this is the point where we are going to talk about amyotrophic lateral sclerosis, otherwise known as Lou Gehrig's disease. And don't worry, this is not my drool on my t-shirt. This is my daughter's drool because I just put her to bed. But on a serious note, ALS is an absolutely brutal disease process, a neurodegenerative disease. And this is going to be a serious video. I'm not going to be making any jokes about this because of all the diseases that I treat and all the diseases that I have made videos about so far, this is probably my least favorite because the people that I have treated or am treating with ALS progresses very rapidly. So, the etiology of ALS is unknown, meaning we don't understand what triggers it or why it occurs in some people. But there is a certain amount of understanding that genetic mutations are causing this to happen. It does typically affect men more than women. In sporadic ALS, meaning that you don't have a hereditary component to it, it roughly affects men twice as often as it affects women. And then in familial ALS, meaning you have a family member with this condition, it can impact men to women on a 1-to-1 ratio. It's more common among white males and non-Hispanics, and it is the most common adult onset motor neuron disease, typically onset occurring around 55 to 75, but it can manifest in the teens. Most famous instance of this happening is with Stephen Hawking, occurring very early in his life. And then it can also affect the very old. Now, this disease process affects the upper motor neuron and the lower motor neuron, and I'll talk about that here in just a bit. So the pathophysiology of ALS is that we get degeneration of the Betz cells, the anterior horn cells, in the lower cranial motor nuclei of the brainstem. So the anterior horn cells in the lower cranial motor nuclei of the brainstem are the lower motor neurons, and then the Betz cells originate in the primary motor cortex, which eventually then hook up with the corticospinal tract, which is responsible for our motor output that goes from our brain down our spinal cord and then out to the muscles. So that is why we get upper motor neuron and lower motor neuron involvement, and then as these neurons degenerate, gliosis occurs. And gliosis is just when glial cells in the central nervous system, primarily astrocytes, hypertrophy as a result of the excessive space that comes from spinal cord atrophy and atrophy of these motor neurons. And so to fill the space, you get hypertrophy of these glial cells. So the clinical presentation in terms of lower motor neuron signs, you may see muscle weakness, atrophy, fasciculations, hyporeflexia, and hypotonicity. Upper motor neuron signs, spasticity, clonus, hyperreflexia, and pathological reflexes, which would be like Babinski sign or Hoffman sign. So if you have a patient coming to you and they are exhibiting lower motor and upper motor neuron signs, and they haven't received any sort of neurodegenerative disease diagnosis, they absolutely need to go see a neurologist. And you need to send your notes to the neurologist saying these are the upper and lower motor neuron signs that they are exhibiting. So very common signs and symptoms of ALS would be sialorrhea or excessive drooling, dysarthria, meaning difficulty articulating speech, dysphagia, difficulty swallowing, fatigue, pseudobulbar affect, like emotional lability. So this would be like laughing or crying at inappropriate times, and then like a very sudden resolution of that laughing or crying. They can have urinary changes and difficulty with respiration. The urinary changes may not be as common because these motor neurons are actually more commonly spared in ALS. The onset is typically asymmetric, focal, and distal. So the most common presentation is weakness of your upper extremity, so beginning in your fingers and your hands. Second most common is lower extremity, typically starting in your toes, your feet, your ankles. And then third most common is bulbar or facial weakness. Progress of this disease, progress being a negative term here, is continuous. So in MS, you can have remission of active attack, and then you sort of stabilize, but with ALS, progress is continuous, so you don't tend to stabilize. you tend to steadily regress in your ability to function. And then the functions that tend to be spared in ALS are sensory functions, motor neurons to bowel and bladder, your oculomotor ability, and then your cardiovascular muscles as well. And then cognitive function is typically spared. Again, thinking of the most famous example, Stephen Hawking, who was an absolute genius physicist. So you can kind of use him as an example of what is sort of typical of ALS. Prognosis of ALS is poor. The typical life expectancy after onset is only 3 years. So 20% of people that are diagnosed with ALS will survive 5 years after their onset, and only 5% of these people will survive up to 20 years. The people that are surviving up to 20 years or greater after onset are usually people that are younger when the disease process begins. And the negative prognostic factors, meaning that people that are likely to not have as long of a lifespan after onset, are people whose disease process was initiated in the bulbar muscles or respiratory muscles. In terms of medical management, the FDA has only approved 2 medications to treat ALS. One is Riluzole, which works by reducing the release of glutamate. If you watched my Parkinson's disease lecture, glutamate is an excitatory neurotransmitter, and so by reducing glutamate release, you have potentially less excitability of this neurodegenerative process, and it can prolong survival only by about 2 to 9 months, but it is quite an expensive drug. And then you have edaravone, which slows decline of daily function by reducing the oxidative stress to the neurons. And then in terms of what PTs can do to manage ALS, in a systematic review by Lou and Bill in 2009, there was no adverse effect on the disease progression or on survival time in people that were receiving physical therapy. And so we tend to focus on preserving function. We think of this as therapy in reverse, and so try to help them maintain whatever function they have for as long as possible, and then help them learn strategies to reduce energy expenditure, as well as they start to lose function, what other pieces of equipment or other strategies can we employ to help them remain functional for as long as possible. Moderate intensity exercise may be beneficial in the early stages of ALS, and in mouse models they found that moderate intensity exercise had a moderate effect for increasing the mouse lifespan. High intensity exercise is contraindicated in all stages of ALS, so do not be pushing these people up to the 70 to 90% of their max heart rate. We need to keep the energy expenditure relatively low, so think like on a modified Borg scale, we're trying to keep them around 4 or 5 out of 10. This was a hecka long video. It's not fun to talk about ALS. I don't enjoy seeing ALS because I love these patients. They tend to be incredibly sweet, but this is a brutal disease process, and it is not fun. There's no bit of this that is enjoyable except getting to know the person. But other than that, it's difficult to see a person you begin to care for go through the process of ALS, and I really, really hope that we are on the horizons or on the brink of discovering some new ways to treat this, or at least figure out what is causing it so that we can start to attack this head on, because it sucks.